Yeah, good evening, doctors. Welcome to the cardiovascular CBS session. So, CBS session is one of the most important ones. It's basically computer-based session. So, a computer will generate a question, a scenario, and then it will generate a question, and you will have to answer that question. So, I've just kept few important cases of cardiovascular science, which are important from EDIC point of view. So, without wasting much time, we will just start with the class. So, we have a 68-year-old male who presents to the ICU with chest discomfort and shortness of breath. He has a history of hypertension and type 2 diabetes mellitus. Now, this is the question stem. So, basically, what you have is a patient who has come to the ICU with chest discomfort and shortness of breath. So, you see the ECG. This is the ECG that is there. So, can anyone open up their mics and tell me what do you see in the ECG?
Inferior wall ST elevation MI with reciprocal changes in the anterior chest leads.
Okay,
This
so
is suggestive of acute coronary syndrome.
yeah, so basically, when you describe an ECG, you tell that this ECG it looks like a sinus rhythm with ST elevations in lead 2, 3, AVF, along with reciprocal ST depressions in the anterior leads. So, hence the diagnosis is acute inferior wall STEMI. So this is how we reach the diagnosis. Your diagnosis is correct, but you spoke the diagnosis at the first instance. So you explain the ECG first, and then you decipher the diagnosis. Fine. So what would you do if such a patient comes to you in the ER or in the ICU? If this is the patient and this is the ECG, what will you do immediately? What are the two next best steps?
So first we will resuscitate the patient. I will manage the airway, breathing and circulation. I will try to maintain saturation about 95% and taking care of circulation. If the patient is in shock, then vasopressors need to be started. At the same time, I will proceed with percutaneous coronary intervention if my hospital has the facility to do so, or maybe thrombolysis depending on the hospital.
Anything before that?
Dual
So
anti
we all know that PCI has to be done, but there is something that you have to do before that.
aspirin 300 milligram and cloplet
Correct. So
300
we
milligram.
have to give antiplatelets immediately. So it has been seen that when the antiplatelets are given almost instantly, for example, those patients who are either doctors or medicos or know that they have to take aspirin, those patients, when they take aspirin immediately on the onset of chest pain, they do extremely well because it decreases the thrombus load in the coronary arteries. So the first step that you have to do, you have to give them, load them up. That is the loading. Word is loading. That you load them up with aspirin and another antiplatelet agent. So what is that technique known as? This is known as DAPT. That
So
is dual antiplatelet therapy. So you have to start the dual antiplatelet therapy immediately. So when we discuss about DAPT, immediately the next question comes, what DAPT? What two drugs that you will give? So first is aspirin. That is the common one. That is essentially the common one. One, because it can be dissolved. Second, it has the maximum data. So most of the studies that have been done till today, they include another drug with aspirin. So aspirin is a standard. If you don't have the another drug, that is fine, but aspirin is the standard. So you have to give aspirin plus something else. That something else could be clopidogrel, it could be ticagrelor, it could be prasugrel. I was on my phone, but my laptop has just, it has got charged. So if you are okay with it, I can shift to there. If you're okay, we can move there. Sana?
Yes, of course.
Can we do that?
Yeah.
Because then I'll have a pen to work with. Yeah.
Yes, sir, sure, we can. Please.
Okay. Thank you. Bye. So what we have here is, number one, we have ST elevations and we have ST depression, which are reciprocal changes. Fine. So we have arrived to the diagnosis of inferior wall STEMI, which is a type of ACS. So ACS is basically a coronary obstruction that could lead to either transmural infarction or it could lead to subendocardial infarction. Subendocardial infarction is non-STEMI, a complete total occlusion leading to a transmural infarction is STEMI. Of course, in a transmural infarction, we have to be very, very aggressive. But the moment you see ECG changes, the first thing that you have to do is, of course, take care of the ABC. Second, simultaneously, so both are one actually, you have to load the patient up with aspirin. Okay, 300 milligrams. And of course, you have to give another agent, which is either clopidogrel or ticagrelor or prasugrel. So the diagnosis we have is inferior wall MI. And how do you define STEMI? Now, that is another question. So STEMI is ST elevation. Then you need to know what is ST elevation. ST elevation is more than 1 or equal to 1 elevation in more than 2 inferior leads, that is 2-3 AVF, with reciprocal ST depression that we saw. If we are talking of V3 and V4, the ST elevation criteria is different. Okay, in males and females age of 40 and above. So in that case, the criteria to define ST elevation is different, that you need to understand. Okay. So in case, whenever we see RV or basically inferior wall MI, now this inferior wall MI, if I have to draw the coronary circulation here, if I have to draw the coronary circulation here, this is the coronary cusps, this is the left main, this is circumflex, this is the LAD, and this is the diagonal. So this is the RCA coming here. So this is the picture diagram of the heart and on the coronaries. Now, you see clearly that there is inferior wall MI. So this is inferior wall. So this is undergoing a infarction. Now you can actually see that some part of coronary arteries, and there is vessel coming from the circumflex also, which provides the same region. So sometimes it is circumflex. That means the inferior wall MI can be because of RCA or it can be because of a branch of circumflex. But if it is RCA, right coronary artery, it may lead to RVMI. Now, this is nowadays very, very important. Why? Can anyone tell me about RVMI? Why it is important these days? It wasn't so important like few years back, but now it has got attention of everyone. Can anyone tell me why? Any guesses? Because it will be important for your exam.
Conduction blocks are present.
Yeah, that has always been there. Right coronary artery supplying supplying the AV sign block. We all know this. But then IABP is not an option. This is why it is important, because till today, whenever a patient of acute MI was going into shock, cardiogenic refractory cardiogenic shock, or had gone into refractory cardiogenic shock, the next device that we would put was IABP, intra-aortic balloon pump. But now it is, because in RVMI it will not help at all, because the RV is pumping blood into pulmonary artery. We are not putting IABP into pulmonary artery. We are putting IABP into aorta. And aorta is connected to left ventricle. So left ventricle assist device is IABP as small as possible. Then are the bigger ones, Impella and all, LVAD. But we do not have a RVAD. So what is the technique that is used to pull out the patient of RVMI from cardiogenic shock? Anyone? This is
It
EDIC
is
level. Yeah, go on.
with volume therapy.
Okay, we have done all of that. The volume therapy we have done. The patient is still continuing in cardiogenic shock. And the diagnosis is RVMI. LV is working absolutely fine. The only therapy that will work there is ECMO. Yeah, nothing else. Okay. So if you have a diagnosis of RVMI with cardiogenic shock and you have loaded up the patient with IV fluids and still continues to remain in cardiogenic shock, there is no benefit of marking IABP as the next modality of choice. The next modality of choice will be directly VA. Okay? Yes? So, when do you consider an RV infarct? Do a right-sided ECG. If there is persistent hypotension, the lungs are clear and the JVP. When this is apparent, then you are dealing with an RVMI. So, you need to do V789. Is that clear? So, plan for PCI or thrombolysis. How do you do that? The PCI has to be done within 90 to 120 minutes, that is up to 2 hours of the first medical contact. If you are not able to do in 120 minutes, then you have to thrombolize the patient. In those cases, the data is same for thrombolysis or PCI. Both of them are beneficial. But the problem is for thrombolysis, you have to go through the checklist of contraindications.